Well, we're certainly pleased that the first visit made that connection for you. And I know we had you back in a subsequent visit a very short time later, and the search committee was extremely pleased, not only with the demonstrated clinical excellence in your surgical outcomes, but also in your leadership skills, your collaborative and respectful and empathetic style. That those were very important things to our institution. So you arrived in mid-September here in Washington, D.C. You've had several weeks now to gain some experience with the nature of our patient population. Uh, we're aware and very sensitive to the fact that in Washington, D.C., we have a high prematurity rate in our births. The children here in Washington, D.C. are born too often prematurely, and that is a driver for some of the technical challenges in congenital heart disease. With your emphasis on the single ventricle, with surgery and innovation in the newborn in particular, what's your experience been like in the first few weeks here in Washington?
So quite rapidly realized that it was a different population that what I was used to in Australia. So in Australia, we had the most complex heart failure patient, but grossly speaking, we were operating the disease coming from an entire population. And the spectrum of disease that I've been facing here in DC is different. So they're not the all comers with congenital heart disease. They're more specialized. And so we have the babies who, as you said, are premature, the baby who have more comorbidities, other affection afflicting them. And we were taking on patients that I had not seen before, honestly. So I haven't seen this tiny baby surviving to the stage where you can do surgery. 1.1 kilo, no coronary arteries, 1.1 kilo hypoplastic left heart syndrome. And you manage to get this patient to the weight, the age where you can do something. And I'm thriving for change, learning, and I have to say I'm learning because these babies' hearts are different. They're thicker, they don't have the same elasticity. It gives a whole spectrum of problem that I was not used to. But that's the exciting bit. I think it's because I think I bring a technical expertise and an ease, I think, in operating tiny babies to a center who's excellent in keeping this tiny baby alive. And so I think the combination of both will be amazing.
So it's really been our emphasis over the past many years to promote the notion of neonatology, neonatal care, intensive care of the child right after they're born and before they're born, children with congenital heart disease and other complex diseases. But we have a team here of nearly 40 cardiologists. There are 14 or 15 cardiology fellows. There are critical care fellows, a 26-bed cardiac ICU. But I'm impressed with the way the team has mentioned to me your willingness to do innovative procedures and to have very good outcomes with procedures that might be considered elsewhere as risky. As I recall, in the last 2 or 3 weeks, there's been a Nakaido procedure. You've done a neonatal Ross procedure and other complex procedures. What's your attitude toward risk taking and how you distribute those risks over the life of the baby?
So I don't hesitate in terms of risk. My profile in my personal life and my outdoors activity, the type of job that I have, my personality, everything is clear in me that I'm happy to take risk. I'm happy to expose myself. I'm happy to take risk. It has to be not stupid though. And so that's where the teamwork is really important. We have today a discussion of a 2.5 kilo baby where we have two options. One option is where we could wait a bit longer and one option is where we can operate directly. I'm happy to operate directly on a very complex operation in this small newborn baby, but I'm happy equally to have the whole team working on that baby. I think that my vision of cardiac surgery is that the outcomes you have is not the results of one person. I am not taking risk. The whole team take the risk. We're all together in that stuff. So at the decision now, the intensivist, the cardiologist, myself, the referring cardiologist, we're all participating for the decision. I'm going to do the surgery. What is important for me, and it took me a while to understand that, is that I'm very relaxed about risk because I know that I'm doing the absolute best for the patient. So if I summarize, and that has gone through my mind many times, honestly, I had the best possible training in terms of adult pediatric cardiac surgery. It's very important for me to give the best to the patient. So I don't drink alcohol. I don't drink coffee before operating. I take care to have a good sleep. I exercise every day. So and you know that I have a discipline of a monk. And so I have the best training. I know that I'm more than half decent in what I'm doing. I know that when I go and offer surgery to the patients, I've given the absolute best I can. And I don't think anybody can compete on that. And so provided that the decision-making is the decision of the team, we all together in that, and I've given my best. So am I taking risk? Yes, I'm taking risk, but in a measured way.